ILS Rescue Commission webinar series. We have representatives from all 4 regions and over 300 registrations, which is a great result for our first session. This session is being hosted by the Medical Committee and will cover 2 topics in the form of a debate. We'll firstly talk about, is hands-only CPR better than traditional CPR in the management of the drowned person? And secondly, do sea collars have a role in modern lifeguarding? One of our speakers will speak against the proposition, another speaker will speak in favour of the proposition. Each speaker will have 8 minutes to present their case, followed by 2 minutes to have a right of reply to the other speaker. We will offer you an opportunity to ask questions, as well as a poll to determine who you think presented their case the best. Use the chat function and you'll find that at the top of your screen, or at least on my screen it is, second one in, and use that for asking your questions. We'll provide written answers to all questions through the ILS website at a later time. We are also going to record this session so that we can also present that to the website. I'm going to move to our first topic, and that is hands-only CPR better than traditional CPR in the management of the drowned person? Our first speaker is Dr. Justin Semstrop from the USA. He will speak against the proposition, that is, hands-only CPR should not replace traditional CPR for the drowned person. Justin, your time starts now. You have 8 minutes.
Hey, good morning. Thank you very much, Peter, and thank you very much to everybody for joining us here. It's about 3 o'clock in the morning in the States, and as many of you are aware, we sometimes have an obesity problem, and one of our favorite haunts here in the United States is Walmart. So if we have somebody who is 65 years old, who is a regular smoker, who may be overweight with coronary artery disease, gets up, has their bacon and yolk-only omelet in the morning, and then decides to go to Walmart. And when they arrive, the parking is full, so they have to park way over there and essentially give themselves a stress test walking through the parking lot. As they take one step past the greeter, they collapse and go unconscious. The reason is because their heart went into ventricular fibrillation, VF, or ventricular tachycardia, VT, and they have had a sudden cardiac arrest. Besides cholesterol, they still have oxygen dissolved in their blood. So the first arriving person who witnesses this should just start doing chest compressions in order to try and circulate the blood, the oxygenated blood that is already there. But that's not going to terminate the rhythm. What is an AED. So the next arriving person should use that defibrillator to knock everybody out of the way and hopefully restart the heart into an organized rhythm. So that's kind of the public health general CPR course that we teach to everybody because of its simplicity. And even for lifeguards, that may be the type of cardiac arrest that they encounter most frequently in their life. But for drowning, if you have somebody who is otherwise fit and they're trapped underwater and their oxygen levels starts to drop 100%, 90%, 70%, 20%, 0, at some point from being underwater without oxygen, the heart will stop. So if you pull them out of the water and start doing compression only CPR, all you're doing is circulating blood with no oxygen in it. That is not effective. So in order to effectively get oxygen to the brain and interrupt their drowning process, rescue breaths have to be given so that the chest compressions can be effective in any form at all. Taking that one step further to the AED, less than 10% of your drowning patients will be in a shockable rhythm. And those that are in a shockable rhythm will usually have some form of underlying heart disease. But the careful lifeguard will see that it was a competent swimmer, whether they were swimming laps or out competently surfing, and then suddenly collapse, meaning they kind of had the Walmart style heart attack when they were out in the water. And the focus should be on compression only and the AED. But if they're drowning and their oxygen levels are dropping, and then that's what triggers their heart to go into VF or VT, then the AED is not likely to be effective without first replacing the oxygen. To use a slightly more inelegant analogy, it's similar to an automobile. You can think of VF and VT type arrests as the electrical system is not functioning, but there's still petrol in the tank, petrol being oxygen. And so if the battery dies, you need to jumpstart the car. If you run out of petrol, drowning, running out of oxygen, you have to refill the petrol tank before you attempt to restart the car. And so that's why it's so important to do compressions and ventilations in drowning, as opposed to hands-only CPR in drowning. And with that, I will yield the remainder of my time.
Thank you very much, Justin. You've just brought me back on what my objective is to finish on time, so I do thank you for that. We're going to move to our second speaker in relation to this, and that's Dr. David Spillman from Brazil. David, just before we move to you, I do notice that the president of International Lifesaving Federation has joined us, Mr. Graham Ford AM, so welcome, Graham. So David, over to you for your presentation.
Thank you, Peter. Thank you, everyone, to be here. I will try to present it. So the question is hands-only CPR better than traditional CPR in management of drowning patient? So this is a real world. I agree totally with Justin, but the reality shows different things. Let's see this, how I had trauma patient after taking a wave. He had probably a head trauma and he was unconscious at the water, drowning. And he was rescued. And I will move forward a little bit. This is, they take him out, and then he start hands-only CPR, and there is no ventilation at all. You can see that this is a real thing, a real situation that comes out at the end with a good outcome. So I would say for the question, I would say yes and no, and I will explain in very short brief words what is about. So why we still question about this? The reason we are still question is almost every drowning papers is about expert opinion. So we deal with drowning and science in a low level of evidence. So that's why we still question about this. But here are some facts that I know Justin already said to us, there's a different mechanisms of a cardiac arrest may elicit different better solution. Sudden cardiac arrest may still have oxygen in the blood to resuscitate depending on time a rescue arrives. Cardiac arrest secondary to hypoxia, less drowning, does not have enough oxygen in the blood to resuscitate. Cardiac arrest on drowning represent 0.01% of lifeguard intervention and 0.5% of rescues. On a critical drowning situation, respiratory arrest occurs 30 seconds to 2 minutes before cardiac arrest. And hands-only CPR means passive ventilation by providing 1/3 of mouth-to-mouth ventilation. And that's the reason when we do hands-only CPR, they still work. So, but it's important to notice that hands-only CPR is for BLS, made by layperson, not health profession. So, by consensus among drowning experts, ventilation or use oxygen on drowning cardiac arrest is still a need. So, am I allowed to do hands-only CPR on drowning? Yes and no. If you're doing CPR in water, the answer is no. You better do ventilation in the water. If you do CPR on dry land, you have to know that it's easy to do hands-only, it's easy to learn, can be the only alternative in facial trauma and difficult airway access, can be an option when infective transmission is a high risk for the rescuer. And for example, if the victim is foamy and has emesis, may easily dissuade a provider to do something. Impossibility to, and also at the end, an impossibility to apply by the environment, by the condition of the environment. But still, it will not provide the best for the drowning victim. So thank you.
And thank you, David. We will have a chance for Justin to respond. Justin?
All right, thank you very much, Dr. Spilsman. As you mentioned before, we both agree on this position, and so in the context of the debate, I would just add that it's a matter of how we are defining better. Is hands-only CPR better than traditional CPR? And I would say that if our definition of better is improved outcomes, then traditional CPR is better. If our comparison is doing nothing, then hands-only CPR is better than doing nothing. And one other subgroup where I still recommend hands-only CPR for laypersons in drowning is sometimes when we're providing pre-arrival instructions over the phone. And to properly give rescue breaths requires training to do it properly, and giving rescue breaths improperly can cause them to go into the stomach, which can induce vomiting, which can make things worse. And for a trained rescuer, be it lifeguard or lifesaver, firefighter, first responder, police officer, then the best outcomes come from compressions and ventilations. But if we're comparing untrained bystanders, the soccer moms, the accountants, the judges and the mechanics out there who are performing it sometimes for just the one time in their life with no prior training, then hands-only CPR may be better. Thank you.
David, do you have a response?
Yes, Justin is the better version of myself. So I agree entirely with him. And I just want to reinforce that when you have nothing to do, or you are unable to do something, or you don't know what to do, hands-on CPR is better than do nothing. But for drowning, it's better always. It's better if you do ventilation, as the heart stops by the hypoxia. You need to reverse hypoxia, and that's it. Thank you.
Thanks. Thank you both, Justin and David. We have an opportunity for some questions, and may I start by asking you both the same question, and that is, has COVID changed the way we think about traditional CPR? And I'll throw to Justin first.
Thank you very much, Peter. And I would really define COVID from yesterday as being a completely different entity than the COVID of 2 years ago, without getting too much into the subvariants of the BA4 and 5 that we're seeing now. We're gradually trending towards a more mild illness, as opposed to the more serious illness that we saw with the first two and even the first three waves. And to say that a professional rescuer, in the context of their duties, should have the appropriate equipment to adequately start compressions and ventilations in a drowned person. And for the most part, a drowned person is going to be lower risk because they were healthy and well enough to get themselves in the water. Again, painting with a broad stroke there. But in low and middle income countries, as well as in non-drowning cases, then the risk for CPR may be greater, but there are algorithms that are available. One that was put out with IDRA, ILS, and the IMRF on the decision-making algorithm for whether or not the person was so high risk that it was better that doing compression-only CPR was better than doing nothing.
Thanks, Justin. David, do you have a comment?
Yeah, honestly, I think we are overreacting about this. That's my opinion. As we saw for HIV, and people don't want to do mouth to mouth because they are afraid to have HIV, and we now know that the possibility to acquire HIV, which is now treatable, but in the past was not, and the mortality is totally different from COVID-19. I would say the chance to be to die after mouth to mouth on a drowning patient by COVID is 0.0 something. So our fear for this is overestimated.
Thanks, David. We do have a number of good questions, and I'll repeat that we will provide written answers to all questions if we run out of time through the ILS website. And the question is, should we advise our trainers to start with 2 ventilations and then compressions, or the other way around? Justin?
Yep. So I think that for a trained lifeguard or a lifesaver, that whether it's starting with 2 ventilations or starting with 5 ventilations, we don't know that exact number. I know that I personally and many of the training organizations in the US advocate for starting with 5 ventilations, because there's going to be foam, there's going to be airway resistance, there's going to be vomit, and so sometimes it takes 5 tries to give 2 effective breaths. But the key is, if you're going to be giving to breaths of any kind, whether first or second, it's to make sure that they are effective breaths that are actually causing the chest to rise and fall. And the reality is, if you're 8 minutes into it before the AMBO or the paramedics arrive, then it may not matter for their outcome whether you start with breaths or compressions, as long as both are being performed.
Thanks, Justin. I do notice that there's quite a few people now starting to put their hands up to ask questions. Can you please use the chat function? It's going to be very difficult for us with over 100 people online to single people out. David, I'll direct the next question to you. On average, in non-drowning patients, how long can compression-only CPR be performed before the circulating oxygen is used?
Yeah, let me see if I understand the question. You're saying how long we should keep doing CPR in a known drowning patient?
So this is for a hands-only CPR. How long is it effective?
Yeah, for drowning, we still recommend a long time because of hypothermia, because of the possibility of being resuscitated. So I would say an hour, but you will need many people helping you out. I was many times at the beach resuscitating people from drowning. And one time I stand there by an hour and 15 minutes resuscitation, and the patient is very well right now. So I would say an hour, but you still need people to helping you out.
Thanks, David. Can I just remind everybody, we are going to have a bit of fun with this tonight, and we do have a poll in the chat. So if you go into the chat, you'll find a poll. If you can put the comments in there, who you think actually won the debate or who you think presented the best. We'll see between David and Justin who comes out. Bearing in mind they both have exactly the same proposition. So the poll will be in the chat function for you to work out who you thought was the best tonight. We do have another question, and I'll put this to David as well. Are you aware of any studies that have been done using a CPR dummy immersed in water to see if breaths are needed or not? So in other words, have we done experiments on dummies to see whether they actually breaths work?
Yeah, I'm not sure I understand also this question, but as far as I get it, there is when you do research on dummy, is very different from the real world, and then we can see that with a few dummy papers that is revealing or describing something that is impossible on real life. I'm not sure I answered the question, but that's my view.
Thank you, David. So thank you all for the questions you've had so far. If you have other questions, please continue to use the chat function. As mentioned, we will make sure that every question is answered in written and on the ILS website. Please submit your poll. Once you've ticked either David, Justin, or undecided, and you've hit submit, then you can finish the poll.
Can I say a final word, Peter?
Yes, you can, David.
I can't believe I have 36%. I would say I need 0%. So that's something that went wrong. Thank you.
Good.
Very good. And for my last 15-second final word, I'll just say that for all trained professionals, which includes volunteers, those that have a duty to respond should be doing compressions and ventilations. And compression-only CPR is a bridge to AED in sudden cardiac arrest for untrained person. So presumably everyone on this, or most everyone on this, is a professional that should be doing compressions and ventilations. And don't forget that people can have Walmart heart attacks in the water walking through the parking lot, and the very keen lifeguard or lifesaver will recognize that difference and that nuance and emphasize the AED as the priority over the ventilations as the priority as in drowning. Thank you so much, Peter, for bringing us all together, and thank you, Dr. Spillman.
Thank you to both David and Justin. I want to move on to the second topic, and that is, do sea collars have a role in modern lifeguarding? The first speaker is Dr. Gary Payinda from New Zealand, and he will speak against the role of sea collars in modern lifeguarding. So Gary, over to you.
Thank you, Peter. Just want to check for a second. Think you can hear me all right?
Yes.
Wonderful. Thanks for the introduction. Welcome, everybody, and my regards to Leo. So I don't want to intimidate you with all this small print, but I wanted to put the references up front so that if you want to go back and look at a screenshot, you have them available to you. We're going to discuss these today. Next slide, please. So for 60 years, we've been taught, don't move the patient. If they've had a potential of a neck injury, get a C collar on, immobilize that C spine. And that's what we've been doing. But I want to talk about whether what we've been doing is the right thing. Next slide, please. Since 1964, for about 60 years now, we've relied on a piece of plastic and foam to prevent paralysis in patients. Next slide. That would be a safe thing to do, and C collars would be a good intervention if they immobilized the C spine effectively, if that immobilization prevented paralysis, and if C collars caused more benefit than they do harm. And I think you'll see in the next few slides that they don't do any of those things. They don't achieve any of these cardinal functions. Next slide, please. So this is a list of the scientific studies I could find, good reliable studies, that showed that cervical collars prevented neurologic disability or compromise, prevented paralysis. There are none. And that's an issue. They've had 60 years to accumulate the resounding data to show us that these things prevent paralysis, and unfortunately we don't have that. Next slide, please. These are some of the problems of C collars that I'm going to get into. They actually do cause significant harm, and if they don't, for that harm, if they don't reduce the risk of paralysis, then we really have to ask ourselves, should this be a gold standard? Should we have been doing it as long as we did? Next slide. Next slide, please. So any of us who've applied a C collar know that once you put someone in spinal immobilization of any kind, it causes delays. You are less able to extricate the patient. It's much harder to handle them. You've got much graver risks of aspiration, and you in general have slowed down their care and really increased the complexity of the resuscitation. Next slide, please. There's always an issue that when there's a C-spine injury, there may be a brain injury as well. And we know that immobilizing people in uncomfortable collars increases their agitation and increases their movement. That's not a great idea. We know that it increases aspiration risks. This middle slide shows us a gentleman, and if you pay attention to his gown, he's got some vomitus on his gown. He was agitated, removed his collar, and then replaced it as best he could. He put it on upside down. And I would argue that it's as ineffective upside down as it is right side up. Next slide. So the C collar, because it goes around the middle of your neck, does a modest job of relatively immobilizing some of the middle vertebrae. But of course, it translates more motion to the high C-spine and the lower C-spine. We call this a hinge pivot effect, and it's been shown in MRI studies, both on living humans and cadavers. And we've got a structure that anatomically doesn't make sense. It's not immobilizing as much as it is translating movement to the areas that can least bear it and that are the most likely to be fractured. Unfortunately, also, you've got the fact that it increases intracranial pressure by decreasing the venous return from the brain. And what you have then is a situation that's not good for brain injury. In other words, one where intracranial pressure has increased. Next slide. We talked about aspiration risk a minute ago. Imagine that you are a C-spine injured patient in pain, now restrained with an uncomfortable collar that restricts your jaw movement. You can't open your mouth to spit, to clear your airway, to deal with blood and vomitus that's in the airway. It's hard to roll. These are the last things you want to do in a resuscitation. Resuscitation really should be focused on the ABCs, airway, breathing, circulation. And putting a collar on compromises your airway, your breathing, and in some ways your circulation, especially if we talk about intracranial pressure. Next slide, please. Despite all of these harms, C-collars would be worth it if there was proven efficacy to them. If by putting a collar on, you protected this spinal cord and you had less paralysis as a result, it would be well worth it. But the studies, the few good studies that have been done, come up with findings like this one. This is a study that compared two health systems, 400 study participants over 5 years, controlled for the injury mechanism. So they tried to match these two groups. And what they found was in the one group where no collars were used, no spinal mobilization, they actually had twice as good neurologic outcomes as the health system that extensively used C-collars and immobilization. And I think that was a big wake-up call to us that maybe what we're doing, what we assume to work, doesn't. And perhaps some of these small harms are additive and create an intervention that we shouldn't be putting on patients. Next slide, please. So this is the slide I want to wrap up on. I would say avoid C-collars in general because they cause no proven benefit, but do cause real harm. We have enough studies now to understand that. Whether you're talking about aspiration or skin breakdown or intracranial pressure problems or difficulty with handling. Next point is that moving a patient to safety is always going to take precedence over spinal immobilization. Performing the ABCs, so airway, breathing, and circulation, is always going to be the first thing you focus on rather than immobilization of the C-spine. And little by little, resuscitation councils, like the one I sit on, and New Zealand Resuscitation Council, have come around to this way of thinking and reprioritized how we handle trauma patients. Thirdly, with less than a minute to go, conscious patients can determine their own self-extrication, their own ambulation and head position, guided by their comfort. A neck-injured patient knows what hurts them better than you do. And as long as you're not doing unnecessary handling, the vast majority of conscious patients can manage their own C-spine. Unconscious patients can receive what you see there, manual inline stabilization. Things like towel rolls that provide a modest degree of support. They eliminate excessive unnecessary movement while still allowing you to do the ABCs and extrication safely. That's the end of my time, and I hope that was helpful.
Thank you very much, Gary. We have our second speaker now, and that is Leo Menino from Argentina. He will speak in favour of retaining C-collars, and thank you for your questions. I see some coming through. So over to you, Leo.
Hi, thank you, Gary. Thank you, Peter. Well, okay, next slide, please. The spinal cord injury in aquatic environment is low or extremely low. The incidence may vary between 0.009 to 5, depending on the casualty ages or the aquatic facilities. The cervical collars have been routinely used for trauma patients, as Gary said, and maybe in lifeguarding for the same time. Spinal motion restriction has gained in favor over spinal immobilization. Current techniques limit or reduce undesired motion of the spine, but not provided true spinal immobilization. So SMR is an attempting to maintain the spine anatomic alignment and minimizing gross movement, irrespective of adjunct or devices. There are no studies, as Gary said, that directly address outcomes such as neurological injury, survival, or hospital length stay. Next slide, please. Some studies document how the application of rigid C-collar limit motion of cervical spine. C-collar reduce the range of movement. The movement is decreased, but do not eliminate cervical spine flexion. Different issues were documenting as well during the implementation. Intracranial pressure can cause pressure sores, obscure neck injury signs, produce axial forces. A significant issue associated with C-collar could be the increased difficulty during airway management. That's why we need to treat a critical condition casualty, prioritizing AVC first. Next slide, please. What about the evidence in the international bibliography? Not much evidence, really. The advanced trauma life support by the American College, as others, they all state that C-collar are effective in limiting motion of the cervical spine and should therefore be used until the patient is properly assessed and the cervical spine is clear. An appropriately sized C-collar is a critical component of SMR. The spine should be stabilized by keeping the head and neck torso in alignment. The I-collar, not that the ability to properly apply a C-collar is not a skill typically taught in the first aid courses, right? But although some large group of first responders may receive specialized training and regular practice to allow them to use cervical collars as a sport-related injury. So what about lifeguards? Next slide, please. The European Resuscitation Council, the Red Cross, and the American Heart Association, the Australian and New Zealand Resuscitation Council all recommend almost the same. No routine application of C-collar by a first aid provider and manually support waiting the EMS arrival. The lifeguards are more than first aid provider, right? I mean, are professional, have a duty to respond to emergencies. And do we really get the EMS available everywhere? Next slide, please. When to proceed with this protocol, the American Joint Consensus of SMR state that the protocol should be applied in prone trauma incidents for adult and pediatrics, based on findings and symptoms. Decisions are made to apply SMR, including a C-collar. But in the water rescue, the lifeguard needs to decide without the initial assessment, so the recognition of high-risk mechanisms of a possible injury continue playing a role here. As mentioned in the protocol, a diving incident, axial loading, lateral bending forces, or violent impact to the head are consistent with potential spinal cord injury due to mechanism of injury and are considered high-risk incident. So are stronger consider of SMR here, initially using manual support, right? Next slide, please. When not to proceed with the SMR protocol, never in critical injury trauma casualty, there is no role for penetrating trauma. SMR means less chance of survival, twice death rate in that cases. SMR not necessary for a reliable, awake, and alert victim that is capable of holding his or his own head and neck in a stable position without pain, with no neurological finding, not intoxicated, doesn't care, doesn't hurt, and everything works. Okay, no need SMR, no need C-collar. Next slide, please. To sum up briefly, Education of pre-hospital personnel, including lifeguard or first responder in emergency care, is critical to improve spinal cord injury management using SMR protocols. Next. We need a safe and effective strategy for lifeguards based on SMR protocol, not including routine use of cervical collar. Temporary use of sea collar is an option after manual stabilization and extrication or during moving procedures and transferring the casualty. Maybe providing support during certain maneuvers. Also, the EMS personnel could remove after the medical assessment. And SMR, finally, the SMR should never ever delay life-threatening interventions in a critical injury trauma casualty. In critical trauma patient, we should attend first of all AVC and support the head manually if possible. Thanks.
Thank you very much, Leo. So Gary, you have a right of reply to anything Leo said or add anything else you would like to say.
Well, yeah, that was great, Leo. I would say just a couple things. And in regard to some of the questions as well, I would say that ILS has a wonderful position statement under the medical committee sort of guidelines and statements about C-spine injuries and evidence-based management. So if you want a good resource that's up to date, well written, go check that out. It's on the ILS website, subpage, the medical page, and then just look up cervical spine injury guidelines. I would say, and in answer to, I think Monica asked, why has it not changed? It has in many countries. So New Zealand's ambulance service about 5 years ago went to these. I don't know if you can see this, this band. It goes on the neck and it says cervical spine, not cleared. You put it on a patient and in lieu of a collar, it helps remind people that there's a suspicion of a cervical spine injury. And it has none of the harms that go along with actual hard collars. And then lastly, one thing I didn't get to mention in the talk, and I'll just take a few seconds to do this, is that in the old days, the bad old days, we would be, emergency doctors like me, would be moving patients to the CT scanner and they would become paralyzed around the same time. And we would feel that it was our fault. We let the head move too much. We understand much more about spinal cord injury now. We understand that the force in a C-spine injury is tremendous to break the bones of the neck or to disrupt ligaments that are as strong as steel. And the injury and the energy is transmitted into the cord at that point. And it may only be an hour later or 2 hours later that we see the symptomatology begin, where the patient begins getting paralyzed. In the old days, we believed it was our fault, and so we sought to immobilize C-spines. We now understand that the initial injury set forth a cascade of hemorrhage, edema, free radical oxidative damage, and then a reperfusion injury on top of all that, in addition to just basic cord swelling. So we now have a better grip on why the collar didn't do the miraculous job we wanted it to of preventing paralysis, because in a bad C-spine injury, the damage is already done. And what you need to do is optimize the patient's ABCs preferentially. So that's it. That's it for me.
Thanks, Leo. A final word?
Yeah, thank you, Gary. Probably only a few casualties in the lifeguard time need need SMR, and probably a sea collar as an action in a quiet environment or less in a water-related incident. So I think that protocol should be addressing the correct assessment, handling, and identifies high risk casualties. Of course, we have to attend the not produce harm, more harm that already done, and take into account that it's not a role here for any situation about critical condition patients. So maybe we are doing some situation not really to all, not really a routine use of C-collar, I mean, yeah.
Thanks very much, Leo. Before we go to some questions, I'd like to make the point, and Gary talked about the medical position statements on the ILS website, and I do encourage you to have a look at those. And just for make sure you understand, tonight was put together as a debate between medical professionals, as a debate, and to try and draw out the issues that we want to talk about tonight, so or today, or whichever morning, wherever you are in the world at the moment. So there's not necessarily the ILS position statement in terms of which way our doctors have been debating, but basically here to draw out the ideas or the issues that we need to address going forward. So I thank all of our speakers for that. I'll remind you, we're going to have a poll on this one as well, similar to our first set of speakers. So if you go into the chat function, you can decide whether you thought that either Gary or Leo presented their case the better way, or in fact is undecided. So please remember to hit the submit button after you vote, and we'll see who won that debate in some respects. I'm just going to go, Gary, to a question to you first. Are there any circumstances in which you would recommend the use of a C-collar? And there's a couple of questions in the chat function around logistics in pool situations, which is very hard to extract people from. So are there any circumstances you would recommend a C-collar?
Yeah, so in writing, it's easy to say one thing in a debate, but in real life, so I had to write some guidelines for our surf life saving group in New Zealand, SLSNZ, and the one time we reserved it would be if you're doing things like high angle rescue, you're taking people out of deep holes and up cliff faces. You then will go with head blocks and full immobilization and scoops or backboards. You do what you have to in those cases, but in general, that's a very high level of training that those paramedics would have. Often they'll be like helicopter rescue paramedics and things of that nature. So I think there is some role for a collar, not by lifeguards, not in the first aid setting. I don't believe in the first responder setting, except in incredibly uncommon situations of really bad extrications over high angle situations. For the majority of situations that we're going to face on our beaches, there's enough people around, lifeguards, to maintain manual inline stabilization. I think perhaps if you didn't have anyone around, maybe, and an unconscious patient, maybe there would be a role for the cautious use of the collar. But I would always prefer, personally me, towel rolls on either side of the head and a scoop stretcher and getting another hand or two to help maintain. I don't want extra movement. I don't want a head bobbling all over unnecessarily, but I think we can minimize movement using our hands in a much more anatomic, gentle, and physiologic way than a plastic and foam C-collar.
Thanks, Gary. Question to you, Leo. How do we overcome the issue of cost and access in low and middle income countries? You on mute?
Sorry, here we go. Well, of course, it's an issue considering cost in some places, even more in a low resource setting. But we are talking about a low or medium cost, a collar around $20 US, and in a one fit model, one for adult and other for pediatrics. On the other hand, you see around backboards many times made by agencies or a wood backboard, I mean, by agencies or lifeguard themselves, not only to do SMR, although to transport the patient. Considering low resource setting, such as low and middle income countries, the ambulance or emergency vehicle, including EMS, may not arrive or not exceed at all, and lifeguards do the rescue, support the victim, and maybe law enforcement must transport the patient to the hospital on their own means. In those cases, I think that it is necessary the SMR may be including or not the C-collars or another device protocols to determine which are the victims, in which it is important to reduce the movement in the transition during the evacuation, during transfer to an emergency, or knowing that SMR are not for critical casualties.
Thanks. I have a question here that Gary partly or fully answered, though, depending on which way you go from a New Zealand point of view around, and I'll get your view on this, Leo, is why has the intervention teaching not changed in education of emergency teams? In other words, people are still pushing the expensive, complicated C-collars in all of our training rather than a simpler version.
I'm happy to go first, and then Leo, if you'd like to respond from your continent's perspective. Mine would be that medicine is a conservative field and tradition is slow to change. We know from evidence that and data that when you have a paradigm shift, when you have something that challenges the way we've been doing things, it can take up to 20 years for that change to sort of trickle its way down to the provider level. We don't all work in universities. We don't all train registrars and interns. And it can take a lot of motivation to be up on literature and to want to change and to try to change the focus of a rescue agency. Also, some countries have really significant issues with medical malpractice that slow their adoption of new and different models, even if they're better, safer, more appropriate. There's often an issue of just change in general and change management. So I think those would explain why some countries have been quite cautious or slow to change procedure, and others have been more quick to change it. That's my perspective, at least from what I've seen in North America and Australasia. Leo?
Gary, Leo?
I think that is changing, but it's slowly. I mean, the not the C-collar thing. I mean the full immobilization thing. Many years ago, so no way to think in another way. Now are changing, so you have to select which patient decide to apply SMR protocol, but it's changing slowly here as well.
Thank you. What I would like to do is wind up and say thank you, everybody, for your questions. I'd certainly like to thank our 4 speakers today, Gary, Leo, Justin, and David. As noted earlier, we will respond in writing to all questions. We have recorded this session, and this will also be uploaded to the ILS website. I particularly want to thank Surf Lifesaving Australia and their CEO, Adam Weir, who's also the chair of the ILS Rescue Commission, for hosting and putting these webinars on. It was a shared thought between the Medical Committee and the Rescue Commission, and Adam was at forefront of driving these forward. This is the first of 3 webinars to be presented by the International Lifesaving Federation. Next week at the same time, the rescue operations will present the how to manage flood impact, and secondly, technology in lifesaving. That'll be on the 5th of July. And the week after, on the 12th of July, the Education Committee will be presenting on recycled CPR mannequins, and you get to hear David all over again. Removal of C-spine injury from pool without equipment is one of the questions basically we had earlier. Teaching drowning prevention in those who have limited access, and that'll be the as you go. We do have the results of the polls. So the first poll had 44 people responded, 18% were undecided, and 18% thought that David won the or had the better case, and 64%, so the overwhelming majority in favour of Justin in terms of his presentation. Results of poll 2, who do you think had the better argument for the question, do sea collars have a role in modern lifeguarding? Gary scored 69% and Leo 12%, with undecided at 20%. So thank you all for your contributions and in having those polls. I'd like to just remind you that we do have a survey, which is again in that chat function. We are very keen to understand whether or not you feel that these webinars, and tonight in particular, was something that you would like to see going forward, and ideas for future topics for the medical committee to debate. And also, if you would like to put your voluntary, of course, your email address on it, we can respond to you directly and send you copies of the actual written responses as well. So thank you all again for your participation and for giving up part of your day or night, wherever you are in the world. So from me, goodbye, good luck, and stay safe. Thank you.